Good morning. Today's topic is trauma from occlusion or the periodontal response to external forces. The effect of occlusal forces on periodontium is influenced by the magnitude, direction, duration, and frequency of force, how it is acting on the tooth. The periodontium responds with a widening of the periodontal ligament space, increase in the number and width of the periodontal ligament fibers, as well as the density of bone to increase the magnitude of the occlusal force. Change in the direction of occlusal forces causes reorientation of the stress and strain within the periodontium. The response of the alveolar bone is also affected by the duration and frequency of the occlusal force. What do you mean by the trauma from occlusion? When occlusal force exceeds the adaptive capacity of the tissue injury results. The resultant tissue injury is termed as trauma from occlusion. That the injury is termed as trauma from occlusion. So also known as traumatism or occlusive trauma. Trauma from occlusion refers to the tissue injury, not the occlusive force, The occlusion that produces the injury is called traumatic occlusion. The injury is termed as trauma from occlusion. The occlusion is termed as traumatic occlusion. What is the classification? The classification, depending on the onset and duration, is classified into acute trauma from occlusion and chronic trauma from occlusion, depending on the duration. Depending on the cause, it's classified into primary trauma from occlusion and secondary trauma from occlusion. What is acute trauma from occlusion? The acute trauma from occlusion results from an abrupt occlusal impact produced by biting on a hard object or any restoration or a prosthetic appliance that interfere. Alteration in the direction of occlusal force on the teeth. Acute trauma results in the tooth pain, sensitivity to percussion, and increased tooth mobility. May also produce cemental tears. With excess occlusal force is dissipated, the injury heals and symptoms subsides. Otherwise, will lead to periodontal necrosis accompanied by abscess formation, or may persist as a symptom free, or may lead to chronic conditions. Then it is termed as chronic trauma from occlusion. It's the commonest one. Develops from a gradual change in the occlusion produced by tooth wear, drifting tooth movement, and extrusion of the teeth, combined with the parafunctional habit such as bruxism or clenching, rather than as a sequelae of acute trauma from occlusion. In summary, the criteria determines whether an occlusion is traumatic, whether it produces a periodontal injury, not the teeth that occludes. The occlusion force, the occlusion that produces the periodontal injury is considered as a traumatic occlusion. That injury is termed as trauma from occlusion. Not all the malocclusion doesn't produce any trauma. Coming to primary and secondary trauma from occlusion. When trauma from occlusion is a result of alteration of occlusal force, it's called the primary trauma from occlusion. The resultant of an alteration in the occlusal force. But the tooth and the periodontium is normal, but the force is excessive. Then it is called primary trauma from occlusion. The trauma from occlusion results from the reduced ability of the tissue to resist the occlusal force. It is known as secondary trauma from occlusion. Either here the occlusal force may be either normal or abnormal, but the tissue is reduced or tissue is abnormal. Primary trauma from occlusion is considered as when the etiological factors that mainly the insertion of high filling or prosthetic appliance that creates excessive forces on abutment or antagonistic teeth, or drifting out movement or extrusion of teeth in the space created by unreplaced missing teeth, or orthodontic movement of tooth into an unacceptable position. Here, the force is excessive, but the tissue, the periodontal condition is normal. Primary trauma from occlusion do not alter the level of connective tissue or the attachment, and do not initiate the pocket formation because of the supracostal gingival fibers are not affected and prevent the apical migration of the junctional epithelium. But in case of secondary trauma, here there is the periodontium itself is affected. The adaptive capacity of the tissue to withstand the occlusal force is impaired by bone loss resulting from the marginal inflammation. This reduces the periodontal attachment area and alters the leverage onto the remaining tissue. This can be superimposed by situations either the normal periodontium with the normal height of bone or normal periodontium with the reduced height of bone or marginal periodontitis with the reduced height of bone. The first one here, I told that whenever there is a proper periodontium with excessive force, it is termed as primary trauma from occlusion. What are the stages of trauma from occlusion? It's called stage 1, that's injury, stage 2, repair, and the third, stage 3, the adaptive remodeling of the periodontium. What happens in injury phase? In tissue injury produced by excessive occlusal forces, under forces of occlusion, the teeth rotates around a fulcrum or axis of rotation, which creates an area of pressure and a tension around on opposite side of the fulcrum. Tension and the areas of both sides, it acts as a fulcrum on the tooth. Depending on the type of force, there can be many histological changes. Slightly excessive pressure, there is a widening of the periodontal ligament and resorption of the bone. In case of tension, there is an elongation of the periodontal ligament and apposition of the one side. There is a resorption of the alveolar bone. The other side, there is an apposition. Tension side, there is an apposition, and in a pressure side, there is a resorption. In case of greater pressure, compression of the periodontal ligament fibers with areas of hyalinization, injuries cells like fibroblast and connective tissue cell leading to necrosis of the area of ligament, changes in the blood vessel, breaking of the blood vessels, increases the resorption of the alveolar bone and resorption on the tooth surface. In case of excessive occlusal or greater pressure on one side. In case of greater severe tension, there is a widening of the periodontal ligament, thrombosis, hemorrhage, and tearing of the periodontal ligament. There also, there is a resorption of the alveolar bone. In case of minimal, there is a apposition and resorption. In case of pressure side, there is a resorption and apposition in the tension side. Pressure severe enough to force root against the bone causes the necrosis of periodontal ligament and bone. The bone is resolved from the viable periodontal ligament adjacent to the necrotic area from marrow space, and the process is called undermining resorption. Coming to the second stage or second phase, the reparative phase. The repair constantly occurs in the periodontium, and the trauma from occlusion stimulates the increased activity. When bone is resolved, the body attempts to reinforce thinned bony trabeculae with new bone, which is called buttressing bone formation. When there is excessive force, the body attempts to repair the excessive force, that the bone formation will be there. The housing, the bone formation will be formed around that buttressing, or that is called buttressing bone formation. Buttressing bone formation occurs within the bone jaw, it is called central buttressing, and if it is occurs in the periphery, it's called peripheral buttressing bone formation. The peripheral buttressing bone formation is also it's referred as lipping. Coming to the third stage, that is the adaptive remodeling. If the reparative phase can't keep the phase with the destruction caused by the occlusion of the periodontium is removed, an effort to create structural relationship which may result thickened periodontal ligament, which is funnel shaped at the crest and angular defects in the bone with no pocket formation. In summary, we will tell the injury phase increased in the areas of resorption and decrease in the bone formation. The repair phase, there is a formation of or the opposition of the bone and remodeling into return into the normal resorption and formation when the occlusal force is removed.